So we're going to shift gears and talk about approaches to SI fusion. So believe it or not, there's 7 different approaches to the SI joint. And I'm going to talk about we'll talk primarily about 3 of them. To give you a little bit of history, going all the way back, and this doesn't go all the way back, but going part of the way back, all the way back to Smith-Peterson, that started these transgluteal flap approaches. And this is an open transiliac subgluteal approach. And you can see the various variations of this, some of which involve removing a portion of the bone that they used to call the innominate bone. And some involve screws, some involve plates. And this has continued to some degree all the way up to the early 2000s. So the anterior column, approaching from an anterior approach, has been done for a long time. I mean, this was popularized, and some of the procedures were done in the mid-'80s. And all the way from lateral transfixation, and we know the implant developed by Mark Riley, the triangular titanium bar, the precursor of that was called the EndoFuse, and that was used to fuse ankles. But this was the start of the modern development. In fact, I started doing SI fusions with 7-millimeter partially threaded screws in the 90s, and then when I was 5 years old, and it was very difficult, I had to get up on a little stool and do that. And then I trained 2009 with the triangular titanium bars, and then the posterior intra-articular placement has really been popularized by guys like Fuchs and Rule, Wise and Dahl, and this has been a time-honored tradition. And then we have variations of this posterior approach to be used with bone grafts or with screws and support. The bottom one, is an extra-articular recess distraction arthrodesis, and this technique is the open technique that I actually use today, originally described by John Stark. And this is putting a large screw in there with lots of bone graft, and this is extra-articular recess decortication, and this is coded as a 27280. This is an open approach. But when you compare open versus MIS, MIS wins all the way around. It has better surgical outcomes. It has better pain and functional improvement. It has better operative parameters, less operative time, less blood loss, less days in the hospital, and it kind of hits for the cycle and wins all the way around. Let's go back to looking at the 3 most common approaches. I want to expose you to the posterior approach and then the posterior intra-articular approach. So the posterior approach is something that I think a lot of you guys do, the posterior and the posterior inferior approach, intra-articular. Who has done SI fusion with intra-articular allograft, cortical allograft bone? Has anybody done this? I know Neil has. Really, nobody else has done this. Okay, so the first one, does anybody have any idea when the first posterior approach was done? It was done in 1908 by C.F. Painter, and it took the back part of the PSIS and hollowed out the extra-articular recess and packed the rest of this bone in there. Kept this guy in the hospital 33 days, right? Can you imagine how brutal that was? And the healing took 9 weeks to heal. But that was the first report of the posterior fusion. And then we won't really talk about the extra-articular much, to say that I will describe the technique that is done previously. And this is the screw that I showed you and the technique that I presented previously from Dr. Stark. And this is formerly the daughter screw, now the Nadia screw. This is designed to be placed in the extra-articular recess along the lines of weight bearing. And here's what it looks like on CT scan along with the bone graft. And this is a pretty nice way. You can see the widening of the anterior portion of the joint. This really is a distraction arthrodesis, and this really gives rise to pretty good results. And the precursor to this, the individuals that started doing this is an article from Fuchs and Rule, and this is the early distraction arthrodesis posterior approach that gave rise eventually to the Nadia screw that I just showed you previously. But what we're really interested in is the posterior distraction arthrodesis, the cortical allografts. And the hallmark of these, I would have to say, if you were to say one thing about the posterior cortical allografts, is that they are safe. And they're safe because the neurovascular bundle is clearly medial to this. The lumbosacral plexus and lumbosacral trunk, more superiorly, is also medial to it. So you could go along the axis of the SI joint and really not hit anything until you get into the iliacus muscle, and you would have to go 15 centimeters beyond the anterior border of the sacrum to really hit anything. And what you would hit is Beall. And if you go that far and not know it, then back slowly away from the table, drop the device, never to return. But this is really a very safe procedure, and what it involves is a pelvic outlet view. And so you take the pelvic outlet view, and it's about a 15-degree ipsilateral oblique. You look contralateral down the joint. When somebody lays on the table, if I'm standing here, my SI joints are pointing like this. So if you're ipsilateral to the patient, you do a contralateral oblique 15 degrees looking down their SI joint. And so here's the AP outlet view. Here's the AP outlet oblique view looking down the joint. Here's what it looks like on the lateral view, keeping in mind that the sacral ala are stopped. There it is. Sacral ala are out here. This is the sacral body. This is the sacral promontory. That body and promontory, that's in the middle. That is not where you're working. You're working in the joint. The joint is all the way out here, and the top of the ala is right here. And so you need to make sure and keep that in mind when placing something posterior. So here's the posterior oblique. Here's the final pin placement with the contralateral oblique, outlet oblique. And this is the joint finder and working channel placement. Before you place the allograft, a great view is looking down the outlet contralateral oblique view or the outlet oblique view. With the working channel in place, you can see right through the joint. Oftentimes, when the joint is lax, you can see the widening of the joint. So this is a great view to have. Here's the final placement of the cortical allograft, and this is a very nice placement. And this, according to the SECURE trial, we have data out to a year that says it works about the same as 3 lateral triangular titanium bars, data from the INSIGHT, and the IMEA, and SciFi trials. So let's take a look at the posterolateral view. This is a version of something that goes typically at the level of S1, S2, and will go into the S1 level of the sacral ala. Here's an outlet view. You start in the outlet oblique view, and you aim toward the body of S1 above the level of the S1 foramen. And here's the key view. This is a pelvic inlet view. And so this is the view that has the needle coming down to right here, the border of the anterior border of the sacral ala. The part to stay away from is right here. This is the location of the lumbosacral trunk. Stay away from that. If you hit that, both you and the patient will hurt greatly. So keeping in mind, staying along here, the acceptable trajectories of the needle also include going over here like this. And the pelvic inlet view is just so you know you don't go too far. And there's no reason to go too far. You can see the anterior border of the sacral ala right there very well, very sharp. And the inlet view is something that is absolutely essential to know. And here's the final placement of 2 implants, and we'll demonstrate the posterolateral and the lateral, as well as the posterior approach here in a few minutes. So the advantage is the gluteal muscles end right here. This goes just medial to the insertion of the gluteal muscle, so you don't have to go through the muscles as you want a lateral approach. Here's one I did previously at the bottom of a long segment fusion, of course, so these are quite common. And let's segue into the lateral approach. We have the lateral approach going directly lateral to medial through the S1 bony corridor, through the S2 bony corridor. And here's what it looks like on the fluoro image. We have the anterior border of the sacral ala. We have the bony corridors right here, S1, S2. The vestigial disc is right here between S1 and S2. This is the location of the neural foramen. That's how you know where the neural foramen is on the lateral. So if you stay in the middle of the bone corridors and go right through this, and you don't get too far back, you don't get too far forward, you don't go out into the area where you know the neural foramen is, you can go from one ilium out the other ilium, out the skin, and not hurt anybody. These are safe corridors. This is your safe area right here. And so these are bone corridors, S1 and S2, level of the foramen, and the S1 and S2 foramina, as we see here. And staying within these zones ensures that you're perfectly safe. And if you want a copy of any of these slides, just let me know. I'll email them to you. I've got good teaching slide set. This is kind of abbreviated. It's very abbreviated, so I have a lot better, more complete stuff. And so S1 trajectory, S2 trajectory. And so we start here with the Steinman pin. Really, I start with the Jamshidi, followed by the Steinman pin, followed by the placement of the implant. The placement of the implant is sized based on your dilators. And once we place this, you have the option of putting an S2 guide, and this is something that you can put directly to the S2 bone corridor and immediately access it. The upside is this is trajectory guide. You can't go wrong as long as you put it in the right spot. The downside is you have to have the incision at least as wide as this to be able to get this in the wound. So I don't use that at all. I just freehand it. I find it, I want to keep my incision about 12 millimeters, very small incision. So through the middle of S1 bone corridor, middle of S2 bone corridor, S1 and S2 on the pelvic outlet and lateral views. And typically the sizes for these will be about, and the size of these screws in particular, these are 11.5 millimeters in diameter. And the top one is a 60, the bottom one is a 50. They'll range from 50 to 70 for S1, and the range from about 35, 40 all the way to 45, 50 for the S2 screw. And I always believe in 3 points of fixation. So the Jokar meta-analysis for SI fusion says definitely 2, probably 3 points of fixation is what you need to adequately stabilize the SI joint when coming from the lateral side. So you can place a shorty screw or a foraminal screw. This is a 35 millimeter screw placed in between S1 and S2, or you could put another one in S1 provided you have enough room. So this is a hybrid approach. This is done 100 years ago with Zimmer screws, and these are actually cervical interbody fusion plates, right? So back when this was done, we didn't have anything for hybrid approach, and so we used stone knives and grout we made from lye and stuff we found on the farm. But this is a hybrid approach, and whenever you have somebody that has like a female with chronic grinding pelvic instability, think the 70-year-old female that have had unrecognized SI joint pain for 35 years and has really bad pelvic instability, that's what you'll be doing a hybrid approach on. Here's an example of a case that I had just for fun. This was placed somewhere else, not by me. These are triangular titanium bars. These are, and the fixation here looks quite good. I think this was a very good approach. And I see absolutely no haloing on CT. And I'm not just showing you select cases. I didn't see any evidence of haloing. But the individual, she was a 45-year-old female, kept complaining of pain. You'd inject the joint, pain would go away completely. 6 out of 6 physical examination test positive for SI pain. She had persistent SI pain without what I could see as no loosening at all. So I just revised this with the cortical allograft placed inferior and anterior to these triangular titanium bars. And that was all she needed, just a little bit of distraction arthrodesis, and she did great over time. But this is an example. If you know the anatomy, there's a lot of room in here. This could have been done with a posterolateral screw, right? It could have been done with just what we did here. There's room to revise this without removing the titanium bars that were demonstrably not loose, but yet there was still joint laxity. So out of the 7 different approaches, there are 3 main ones that we do. There are 3 main ones that lend itself to MIS intervention, minimally invasive procedures. And so we're going to demonstrate all of these minimally invasive procedures in the lab. So 3 of the ones that are most common, they have advantages, operative parameters, but people also do better in terms of pain function and quality of life improvement. These techniques are quite easy. I showed you the posterior approach, and I showed you abbreviated versions of the posterolateral and lateral approach. The techniques are very good, especially for people that are accustomed to guiding things under fluoro. And you can combine these, a posterior with a posterolateral or lateral for a hybrid approach, and just know now that there's really no code for a hybrid approach. If you do both, like a 27278, which is distraction arthrodesis, to 7-9 laterally, it will be coded and paid for as a 7-9. But we're working on that. So hopefully we'll get to 2 codes plus a 51 modifier to be able to account for the extra work and extra appliances that you will use for a hybrid approach. My final comment to you, if you don't do SI fusion, is try it. You'll like it. Thank you very much.